Hello, Stephen Lewis. I'm partway through a talk on pharmacokinetics, and I'm now going to talk to you about drug dosing. So I've talked a little bit about the way in which drugs are handled by the body and the concepts such as the therapeutic index. Now talking about how you decide whether or not you're dosing someone appropriately. Now, when you're thinking about what you do when you treat somebody, the amount of drug you give depends on clearly all these factors like the patient you're trying to treat, the disease that they're being treated for, the route of administration that you're going to choose, the schedule. So, for example, for some drugs it's impossible to give it more frequently than once a day. It may be necessary to give it many times in a day. You have to think about concomitant medication. You have to think about what your therapeutic index endpoint is, and to some extent there's things like local policies which are determined, like how you dose a drug is dependent on the availability of staff. So there's lots of different things which affect the way in which drugs are given. Several ways in which drugs are dosed in both pediatrics and in adults, but in pediatrics there's an emphasis on the more refined ways of doing this. The first way, which is common for many drugs, is to simply use a constant dose for everyone, an empirical dose, which has been found to be effective in studies in the past, and so everyone just gets the same dose of that drug. There's no consideration in this of interpatient variability, and the key thing here is that it's only suitable for those drugs which have a wide therapeutic index, so that if you are one of these people who gets very high or very low exposures, it makes no difference because it's still going to work and it's still not going to poison you. So, if you're looking at your therapeutic effect here and your toxic effect here, the whole point about standard dosing is that you have a range of exposures which fall well within a safe range before you get toxicity and when you have optimal effect. So quite a lot of antibiotics are probably some penicillin or cephalosporins are probably the things which correspond to this sort of dosing in adults. Second is dosing which takes into account the fact that people are different. So their weight or their surface area varies, and this is the way we dose for most pediatric patients. And of course that's very rational because we have a wide range of different people, so you're trying to accommodate for the fact that body size is significantly larger or smaller. And of course almost every drug in oncology is done in this way. It can be age related, and there are many examples of changes of the way in which drugs are handled with age, so that preterm infants will get reduced dosing, for example, and then intrathecal therapies are given in different doses according to age rather than to body size, and there are good reasons for that. So in this case, a standard dose gives a range of exposure. Pause here. We're going to edit this bit out. So, if you look at standard dosing, so when everyone gets the same dose of a drug, then this would be inappropriate if in fact what happens is, as a result of your standard dosing, there's a significant number of people who get toxicity, which is shown in the triangle in the bottom right hand corner. So what you really want to do is to reduce the variability in exposure, and one way of doing that is simply to adjust for age or size, whatever, so that your range of exposure is reduced, and therefore the number of people who get the adverse event is also reduced without reducing your overall efficacy. So that is weight adjusted or adapting dosing according to those parameters. Then there's this thing called adaptive control, and what we really mean here is we take something which we know is relevant to the way in which a drug is handled, a pre-treatment parameter, and we use that to define how we treat a patient. So, for example, if you've got a drug which is renally cleared, and you've got a patient who's in renal failure, you make a change to their dose. Okay, and that's fairly constant for many drugs. So here's a situation where you've got activity which increases with exposure and toxicity which rises with exposure, and this is the sort of range that you get with a standard dose if a patient has renal failure. And you simply make a dose adjustment and you find that your toxicity is reduced and your activity remains in an acceptable range. And in fact, the exposure is roughly what you'd expect if somebody didn't have renal failure. So that's adaptive dosing, and it maintains activity while reducing toxicity. The next level that we think about is adaptive control with feedback, and what this really refers to is therapeutic drug monitoring. And this is a case when you've got drugs which have got a very wide range of exposure. So drugs have got highly variable pharmacokinetics. So same situation here, we've got activity and toxicity profiles with increasing exposure, and if you give a standard or weight-adjusted dose, you still have a very wide range. So that a lot of patients don't have ideal activity, and a lot of patients end up with significant toxicity. So what you want to do is to, again, maintain activity by narrowing the therapeutic range. And the drugs that are commonly used with drug dosing in this way are antibiotics such as gentamicin, vancomycin, anticonvulsants, quite a lot of those. Phenobarbital is the archetypal drug that we'd use there. Antiarrhythmics, antifungals, antipsychotics, lithium's not really an antipsychotic, is it? Cyclosporin, which is anti-inflammatory or an immunosuppressant, theophylline, and many chemotherapy drugs. And if you look at the chemotherapy drugs in particular, there are many examples of ways in which people have attempted to reduce the overall toxicity and maintain activity of drugs. In fact, some studies also to increase activity without causing excess toxicity. And we can perhaps talk about some of these later on. Okay, pharmacokinetics, move aside now. So those are the different ways in which patients are dosed, and the most common way in pediatrics is simply to make an adjustment according to age or weight or surface area. But there are cases when we measure levels, and there are cases when you do more complex studies. For example, in bone marrow transplant conditioning, for example, with busulfan, and you measure levels and make adjustments based on those. Alright, we're going to talk about now pharmacokinetics in pediatrics. And this is important because children change. Physiological changes occur with age, so the kids get bigger. The relative proportion of their body compartments changes. You get changes of organ function, and you get maturation of metabolic pathways. Here's a nice graphical illustration of the composition of different parts of the body at different weights and roughly therefore ages. So for example, you might see that the percentage of the body which is extracellular fluid is really very high in an infant, and this falls off fairly rapidly in the first few years of life to what is an adult value by the time your weight is about 30 to 40 kilos. And this will affect the distribution of some drugs which are highly water soluble. It's not an enormous effect, it's 5 to 10% of the body water, but it does explain why some drugs are handled significantly differently in infancy. Body fat changes far more dramatically. So infants have perhaps 10% body fat. This rises very rapidly, and by the time you're an adult, you've got a very significant amount of body fat. If you have a lipophilic drug, then this provides a very substantial store where you can continue dosing patients and they'll continue to absorb it, and the drug will just redistribute into there and act as a sump for a long time. And there are some drugs such as cyclosporin where this is a really very important component. You get changes in organ function, and so examples can be in very early life. You get, for example, relative achlorhydria in the stomach, so you just don't get very much acid production, and you get delayed gastric emptying in early age, but also times of illness. You look at renal function in infants, it is significantly different from in older patients. So at birth, renal function is really very, very low, with the glomerular filtration rate of only 1 ml per minute per meter squared, and at the age of a year, that's roughly an adult level. So if you're dosing with a renally excreted drug, you have to be very careful in infancy, as anyone who's ever done neonates knows. Organ function changes also for drugs which are metabolized by the liver, and this is another example of how a drug like theophylline, or caffeine also, is affected. So if you look at preterm infants, you find that there is a significantly higher volume of distribution and a significantly longer half-life of theophylline, and a significantly lower clearance. So if you give them the same dose as you would to an infant, you find that you cause significant overdose very easily, and these kids can fit, or they can become very twitchy at least. Beyond the preterm phase, it seems that all these parameters are really rather similar. But there are models in adults where, if you're an adult with chronic bronchitis who's a smoker, you find that many of these factors are different again, because clearance rises and you have to give people higher concentrations of theophylline to get therapeutic effects. Just going back, the renal function aspect is important. So if you give gentamicin to a neonate, you find that the volume of distribution is significantly larger. Remember, gentamicin is a water-soluble drug, but also the elimination is renal, so the elimination half-life in a neonate is much longer, and the clearance is significantly lower. In a child, this approximates to the glomerular filtration rate. Chloramphenicol is an interesting example. There's this condition known as the grey baby syndrome. You treat an infant with chloramphenicol, you run the risk of getting a non-specific metabolic crisis, where the child just becomes grey and collapsed, and this used to be thought to be overwhelming sepsis, but in fact it's simply due to accumulation of some of the metabolites of chloramphenicol in a neonate who really can't metabolize the drug very well. If you look at pharmacokinetically guided dosing, so this is drug level monitoring, what are you trying to do? You're trying to produce optimal drug dosing, having thought already about the interactions, the metabolism, and the way in which a drug is handled. It should allow you to make appropriate adjustments to dosing, whether or not the patient has pathological states, and the idea is that you always produce an optimal therapeutic effect. And if you think about what pathological states are important for handling drugs, then there are many. Any system can theoretically influence the way in which drugs are handled. Renal pathological states include changes in GFR, but you can get leaky kidneys, you can get defects of tubular excretion or resorption, and you can end up with high pH or low pH depending on the fluids that you're giving to a patient or their metabolic conditions. If you look at the gastrointestinal tract, then patients can have mucositis. They can stop absorbing because they've got a passive gut, or they can just have malabsorption because of inflammation or because of another pathological process, and that will influence the amount of drug that's absorbed into the patient. If you look at the liver, you can get hepatitic pictures, hepatitis, so you can get impairment of conjugation, and you can get obstructive problems. You can get protein binding, either because of displacement by other drugs, or by induction of induction of production of specific proteins. So you get a higher proportion of a particular drug being bound. And the converse is, if you're starving, you find that you don't produce enough protein, and you may end up getting a higher fraction of your drug being free. Obesity, if you've got an awful lot of fat in your body, then some drugs may be handled differently. And if you're not producing proteins properly, then you may find that binding sites are affected as well. Or, as in the case of, for example, warfarin, if you're not producing proteins and you give warfarin, then you may get a more profound anticoagulant effect. Post-op, you get temporary changes of ileus, of ascites, or changes to the blood-brain barrier after neurosurgery. So, what I'm saying here is that pharmacokinetics are important if the consequences of under- and overdosing are severe, and the likelihood of under- or overdosing is significant. And really, that applies to most of the drugs that we use to treat cancer.